Hi everyone. I'm really excited to be here. I've been asked a few times, I think this weekend, how it feels to come back and see this community grow from the early days. And of course it's deeply inspiring. I think what's most inspiring is to learn with and really witness how each generation of you guys, students, have unlocked your voices and power both as individuals and through our relationships as a community. Relationships that really extend across the globe to imagine and build something that goes beyond, I think, any of our wildest dreams at the genesis of GlobeMed. And so that work of imagining and building has never been more important. I don't need to tell you that there are many things I feel really deeply wrong about with our world. But in a world where we need to work across borders, you might be told that the challenges over there don't matter over here. In a world where we need every person's experience and talent to take on tough problems, you might hear that you don't come from the right background or have the right connections to contribute. And in a world that needs healing and hope, some might wonder if our diverse life experiences are the seeds of intractable conflict rather than the roots of positive change. So I think it's fitting we get to spend this final afternoon of Summit using our experiences and reflections from the past 2 days to begin the work of imagining and building that next generation of our work together. And so to kick this off, I'm going to share my experience of GlobeMed. Like many of you, my time with GlobeMed has been deeply personal. This is a time and a place where I found a way to discover and live my values and found people to share that journey with. Though I had the privilege of being at the beginning of GlobeMed, my story is of course just one of the many that make up this community, as the summit has made clear. So I share this story though with the hope that we might find some questions and ideas that help us enter into a space of possibility. Sound good? So the year is 2005. I was a sophomore at Northwestern looking for a student organization to join. I wanted to make a direct difference in communities facing poverty and poor health. This desire for me came in part from my childhood summers, when my family and I traveled from our home in New Jersey to where both of my parents are originally from, rural West Bengal, a state in eastern India. My father had been born there into difficult conditions, the fourth of 12 children. The villages of West Bengal were still recovering from the Bengal famine in the mid-1940s, when the rice that people survived on there for their daily meals had been diverted by the British to supply their World War II effort. Starvation killed an estimated 2 to 3 million people, Bengalis. Fearing that only a portion of their children would survive childhood, lacking family planning, and with deeply embedded gender inequities, my grandmother would be pregnant some 19 times. To supplement income that came from farming plots of land, my paternal grandfather worked as a village health worker. When he didn't know how to help a patient, he would tell them to go see my maternal grandfather, who lived in a village a few 5 kilometers away. My maternal grandfather, whom I call Dadu, was a rural family physician. Trained in a British-era medical school in the city of Calcutta, he fulfilled a promise to his mother by returning to the communities of his childhood. He served there for his whole life, nearly 60 years after he graduated from medical school. During childhood visits, I remember watching him awake early in the morning to do home visits to rural families and returning to see patients in his clinic until late in the evening. He did his best with the tools he had, a black stethoscope and decades of wisdom from his patients. Yet he and his patients did not have the support of a well-resourced health system within reach. The best hospitals and health centers were hours away. I recall the frightened look on the face of a parent bringing their sick child to him, realizing that it might be too late to get the help the child needed. Many of Dadu's patients lived from day to day, lacking basic opportunities, feeling lucky just to eat, what my dad would call a hand-to-mouth existence. I remember when I'd asked one of my many cousins living there a question I was asked all the time back home. What did they want to be when they grew up? And their silence and averted eyes pained me. Moving between the relative comforts of my home in suburban New Jersey and my family in rural West Bengal provoked an important early question. Why were my opportunities to live a healthy and thriving life so different from the opportunities of my own family members in Dadu's villages? This seemed fundamentally wrong, and I wanted, even in some small way, to be involved in building a different kind of world. So what heartened me at Northwestern was that there seemed to be students who shared this interest in service and social change. They just had taken a different journey to get there. For some, it was a story of immigration, or a direct experience of struggle, or a moment during travel, or a reckoning with privilege. We were brought together in dorm rooms and campus conversations, exploring global poverty and foreign aid, our role as outsiders versus insiders to communities, the Millennium Development Goals, and the possibilities and the problems of social entrepreneurship. But awareness and conversations only seemed to be part of the puzzle. They weren't enough. I thought that the challenge we were discussing required direct action. And at the student fair, I found a group that I thought was doing this, called the Global Medical Leave Program. They seemed to be, what they were doing at the time, they were founded by previous students, was to send medical supplies to health centers and hospitals, and they were also in the process of building a clinic near called the Hope Center, near Ho, Ghana, in the southeast region of the country. So I got involved, pitching in wherever I could, from loading medical supplies into a U-Haul and driving to O'Hare for shipment, to organizing a fundraising dinner to raise money for the Hope Center. But by the time I was ending my first year involvement, the organization was in turmoil due to student turnover, and I decided to step up and lead the group. Given the centrality of the Hope Center to the organization's plans, I felt it was important to visit the project and understand the community better. And so that summer of 2006, I received a student grant from Northwestern to travel to Ghana. There I met Joseph Achana, the local leader we had been working with to develop this health center. He was a stocky man with an easy charm who seemed to know everyone, a true mover and shaker with big ideas for his community. For months, we as students had been raising funds to run the Hope Center, to help run the Hope Center's clinical and public health work. So I was surprised when Joseph took me to a beautiful but empty building with no doctors, no nurses, no patients. I found empty rooms with labels for what they were supposed to be: a laboratory, a nursing team, a pharmacy. Joseph relayed what had happened. The leadership of the Global Medical Leave Program before me had hired a person from outside the community to lead the Hope Center's efforts. In the process, the project's initial supporters, community leaders like Joseph, had been alienated. This new person did not have the relationships or experience to build a hub for health that they all had imagined the Hope Center to be. Yet Joseph felt he had to follow the vision set by our leadership in the US, even as he and others had different ideas for what needed to happen. And so getting out of the car after a trip to a community, I asked Joseph a simple question. Why had he gone along with these decisions? And he turned to me, the look of exasperation on his face, and said, "We're African. We listen to our donors." In that moment and in the days after, questions swirled in my head. Why had Joseph felt like his voice would not be heard? How could we as students listen to people like him and those in his community directly experiencing struggle? And another set of questions came to mind. I wondered, what if someone had come to my Dadu's community and tried to tell him how to take care of his patients? I could only imagine the pain and frustration he would have felt. For the following week, I walked with Joseph learning about his vision. Joseph's idea was to have the Hope Center partner with Ghana's National Health Service to employ and pay trained staff there, while GlobeMed could partner with the Hope Center on community-driven projects that could address critical needs like nutrition and food security. With this partnership, the center could innovate in a way that limited public funds might prevent. So Joseph and I started plotting out how we could gather more input from other members of the community and approach the Ghana Health Service. I left Ghana with some initial plans for partnership with Joseph in motion, but many questions about our role as students persisted. And so returning to Northwestern after my time with Joseph, I met with friends and other students with similar experiences to the ones I had in Ghana. Friends like Peter Luco, one of GlobeMed's co-founders, with whom I had gone on a medical mission at the time in Guatemala, only to realize that what we were doing was probably doing more harm than good. by entering into communities to hand out medicines. One conversation turned into 2, turned into 10, and soon we actually had a small group of committed students here at Northwestern thinking about this. Together we realized we needed to overcome what we saw as a failure of imagination. Failure to imagine students as nothing more than short-term volunteers and local communities as passive recipients of aid. In the process, our energies and talents as students were left unharnessed, while we learned little about improving health or about the histories of those we were working with. And the full possibilities of grassroots leaders were also left untapped, their voices, expertise, and deep experience largely ignored. We needed a paradigm shift. We began to see a different set of possibilities, one where students and grassroots organizations could partner in long-term relationships. We started drawing diagrams, mapping out scenarios, thinking about how this could work. But even as the outlines of this paradigm shift were emerging, we had moments of helplessness. We wondered if this shift was too daunting. Could we as students maintain partnerships? Could we get support and funding for a new model? At times, I questioned my own capacities to help our team walk across this bridge. I still recall a meeting with a leading administrator at Northwestern who told me we were thinking too big. But thinking big was what the moment seemed to require. In those early months and years of GlobeMed, we found hope and imagination, in part from efforts we saw beyond our campuses. The global HIV/AIDS movement had exposed the stark injustice faced by millions across sub-Saharan Africa, Asia, and Latin America, as medicines that could treat the disease remained out of reach even as patients suffered and died. In Haiti, an organization called Partners in Health, founded by young medical students in Boston, had worked for years to build what they had called a preferential option for the poor in health, which included treating people with HIV/AIDS. One of the stories of their patients, Joseph June, moved us deeply. He was a 23-year-old peasant farmer and shoe shiner who for years had experienced a mysterious illness that wasted his body and caused a litany of symptoms. At the time he was brought to Partners in Health's clinic in Haiti, his family had already hired a carpenter to work on his coffin. Diagnosing Joseph with both HIV and TB, physicians at Partners in Health started him on a challenging course of antibiotics and antiviral medications. Over many weeks and months, his appetite returned, and he slowly regained his health. So that's the picture of the before and the after. Remarkably, Joseph June would recover and become a community health worker with Partners in Health. And when, a few years later, the World Health Organization launched a major global campaign to transform the landscape for access to treatment for HIV, his story was at the heart of major policy meetings and documents, reminding people what was at stake. While we as undergraduate students in GlobeMed did not seek to deliver medical care, okay, Joseph June's story and Partners in Health's model offered us a few specific lessons. First, words of solidarity and feelings of empathy for Joseph's experience weren't enough. We needed to do something. We needed to work in pragmatic solidarity, in other words, to put action to our words and mobilize resources that could actually improve people's lives and address fatal inequalities. Partners in Health, in this case, had invested in the staff, health infrastructure, treatments to turn solidarity into a shot at dignity for Joseph and others. And we thought about our partner communities and organizations. As we thought about our partner communities and organizations, this value needed to be at the heart of our approach. Second, this work required long-term partnership, what Partners in Health called accompaniment. As Partners in Health's co-founder, Paul Farmer, has described, to accompany someone is to go somewhere with him or her, to break bread together, to be present on a journey. The challenges experienced by communities we were working with would not end in a day, or a week, or a month, or even a year. Our opportunity to learn and create change needed time, they needed trust. As we thought about our partnership, an African proverb became our refrain. If you want to walk fast, walk alone. But if you want to walk far, walk together. Finally, we came to understand that Joseph June's experience was not the simple result of his choices, but rather the result of what social scientists defined as structural violence. The harm created by specific institutions like the International Monetary Fund, policies such as structural adjustment, and histories, in this case, of racism, slavery, and colonialism. Treating them with full human dignity and doing the work of pragmatic solidarity and accompaniment required understanding this violence and working in a radically new way. Momentum came as we began to realize that students on other campuses were grappling with similar questions and ideas. And so we started to organize the first GlobeMed Summit to bring together students to see if we could work on a new model of student engagement in global health. In March of 2007, 45 students from 7 universities gathered on Northwestern's campus. We heard from inspiring speakers like Joy Mukherjee, the medical director for Partners in Health, and wrestled with hard questions about what our role in global health could be. Crowded around a blackboard, minds collaborating and ideas flying, the pillars of our model, chapters, partnership, a network, began to come together. We decided to start with some initial answers, ones we are building on and adapting to this day. We envisioned a network of student-led chapters partnering with grassroots organizations and communities across the world to improve health. We as students would mobilize funds and resources for projects led by partner organizations and organize trips that would bring small teams of students to work more directly with community members and leaders. Over time, chapters and partner organizations could build trust and collaboration, with partnerships becoming a laboratory for learning and impact. But we also realized we needed to educate ourselves about global health and think critically about our values in order to create the long-term change and engage in effective, equitable partnerships. This education wasn't happening on our campuses and in our classrooms, so we decided to create our own program and dubbed it Global Health U. And as a network of students and partners, we believe that equity in global health would require a movement of young people, each of us committed to leading in the world with a core set of values in a wide array of paths that spoke to our specific interests and aspirations. So events like the Summit and the Leadership Institute would become convening points for which to fuel this larger collective effort. So after graduating from Northwestern, I had the opportunity to lead GlobeMed's global headquarters as its first full-time executive director, working with an amazing team of student volunteers to develop the building blocks of this model. Leaving eventually to start graduate school in medicine and sociology, I've been at times a board member, an advisor, and proud cheerleader over the past decade as the organization has evolved and grown, led by a succession of inspiring people. GlobeMed's model of student leadership and partnership multiplied on campuses, from working with Rwandan students to rebuild clinics destroyed by genocide, to supporting Nicaraguan community health workers to bring clean water to rural villages. We recruited chapter founders and identified partner organizations. We held partner forums in East Africa and Central America and learned more about how we could create change together. The leaders in GlobeMed realized that if we truly wanted to be the change, we had more work to do. We needed to live those values of equity and solidarity and justice as fully on our campuses as we strive to do with our partnerships. They knew that global health equity needed the talents and experiences of all students, but that there were many missing voices and experiences that needed to be part of our community. So we started chapters at universities that previously had not been part of our network, expanding to minority-serving institutions. We re-examined recruitment and inclusion at existing chapters, and we knew this couldn't just be about numbers. True inclusion requires organizational change and transformation, and we had to ensure that our Global Health U curriculum wasn't just geared towards students from certain privileged backgrounds. We had to make sure programs like Summit and Grow weren't only available to students with resources. And most of all, we had to grow as individuals about our awareness that how our identities impacted our encounters with each other also shaped the kind of change we could make. We are in the early days of this work, and like everything else we've done, it's a work in progress. In the process, we've learned the ways, I think, that realizing global health equity is really also about social, economic, and racial justice. So it's essential that we in GlobeMed continue to challenge ourselves to center those questions of inclusion and equity at every level of change-making. Just as GlobeMed has evolved, I've also gone on my own journey. I studied sociology and political economy, trying to make sense of the complex systems that prevent justice in health. Through my research into access to treatment for vulnerable populations, I had a chance to present to the US Senate Finance Committee and the National Governors Association. And then after 4 years of taking a systems level view and approach to health, I was hungry to directly serve and learn from patients. In medical school, I immersed myself on the wards and in clinics from the gleaming hospitals across the street to the West Side Chicago neighborhoods of Austin. I've chosen to make my specialty family medicine, where I'll get the chance to take care of children, women in pregnancy, and adults. This choice came against the advice of many of my mentors within medicine, who thought I should be entering a more prestigious specialty. But ultimately, I fell in love with the idea and practice of being able to take care of anyone in a community and attend to the whole person.